Hi, my name is Morgan Foley, and I'll be giving an overview of delirium as explained by the DSM-5, looking at some diagnostic features. The essential feature of delirium is a disturbance of attention or awareness that is accompanied by a change in the baseline cognition that cannot be better explained by any pre-existing conditions or any sort of evolving neurocognitive disorders. Taking a look at the diagnostic criteria according to DSM-5, criteria A. The disturbance in attention is manifested by reduced ability to direct, focus, sustain, and shift attention, and awareness is reduced according to the environment that they're in. So questions must be repeated because the attention wanders and they are very easily distracted by irrelevant stimuli in their environment. Criteria B, the disturbance develops over a short period of time, usually hours to a few days. It represents a change from baseline attention and awareness, and it tends to fluctuate in severity over the course of the day. It often worsens in the evening at night when external orienting stimuli start to decrease. And then criteria C, there is an accompanying change in at least one other area that may include memory and learning, disorientation, language, or perceptual distortion or a perceptual motor disturbance. Criteria D, the ability to evaluate cognition to diagnose delirium really depends on there being a level of arousal that's sufficient enough for a response to verbal stimulation. Hence, you cannot diagnose somebody in a coma. So the disturbances in criteria A and C cannot be better explained by any other conditions or disorders. Criteria E, there is evidence from the history, either physical exams or lab findings of the disturbance that it's a physiological consequence of an underlying medical condition, substance intoxication or withdrawal, use of a medication, toxin exposure, or even a combination of all of them. So looking at substance intoxication delirium, the clinician must specify which type of delirium. This diagnosis should be made instead of substance intoxication when the symptoms in criteria A and C really predominate in the clinical picture and when they are severe to warrant clinical attention. So there's a lot of coding in this section, and here's when things can get a little bit tricky. But it's very important to acknowledge the comorbidity that comes with delirium. So the DSM-5, there's a table used for coding specific substances when substance use disorder is comorbid with substance intoxication delirium. Each substance has a numbered code, hence this bullet point that says ICD-9-CM and ICD-10-CM. That's a specific table. When diagnosing with comorbidity, the clinician codes either with a mild substance use disorder or a moderate or severe substance use disorder. So, for example, if the individual has cocaine intoxication delirium, they would code it with the terms mild cocaine use disorder with cocaine intoxication delirium. Substance withdrawal delirium. This diagnosis should be made instead of substance withdrawal when the symptoms in criteria A and C really predominate the clinical picture and when they are severe enough to warrant clinical attention. Medication-induced delirium. This diagnosis applies when symptoms in criteria A and C arise as a side effect of a medication taken by the individual. Delirium due to another medical condition. So there's evidence either from history, physical exams, lab findings that the disturbances are attributable to the physiological consequences of some sort of separate medical condition. So when coding each of these deliriums, a clinician will specify the course of the delirium. If it's acute, it means it lasts only a few hours or days. Or if it's persistent, it lasts weeks or months. The DSM-5 mentions that in hospital settings, delirium usually lasts about 1 week, but some symptoms often persist even after the individuals are discharged. It's just all up to the individual. So in addition to specifying course timelines, the clinician will also specify the level of the individual's psychomotor activity. They can be hyperactive. That is accompanied by mood lability, agitation, and or refusal to cooperate with medical care. This state may be more common or frequently recognized and associated with medication side effects and drug withdrawal deliriums. Hypoactive level, it is accompanied by sluggishness and lethargy that approaches stupor. This state may be more frequent in older adults. And lastly, a mixed level of psychomotor activity. There's no normal level, but activity rapidly fluctuates. The DSM-5 mentioned that individuals with delirium usually rapidly switch between hyper and hypoactive states. So that's what it means by mixed level of activity. The recording procedure of delirium, so it would be the name of delirium, which we just went over a couple: substance intoxication, substance withdrawal, or medication induced. It begins with a specific substance that's presumed to be causing the delirium. Then it would be followed by the course, which I just went over, acute or persistent, and then followed by the level of psychomotor activity. So let me just give you guys an example. If you were a clinician, a DSM-5 diagnosis of substance intoxication delirium with cocaine would sound like cocaine intoxication delirium, acute hyperactive. Delirium associated features supporting diagnosis. It's often associated with a disturbance in the sleep and wake cycle. The disturbance can be anything from daytime sleepiness, nighttime agitation, difficulty falling asleep, excessive sleepiness, and even in some extreme cases, the complete reversal of night and day sleep-wake cycle. The individual with delirium will exhibit emotional disturbances such as anxiety, fear, depression, irritability, anger, euphoria, and apathy. There may be rapid, unpredictable shifts from one emotional state to the other. The individual can start screaming, cursing, moaning, or making any other sounds, and it's especially more prevalent at night. I've mentioned this before, because night carries conditions which stimulation and environmental cues are kind of lacking. The prevalence of delirium. The prevalence is highest among hospitalized older individuals and varies depending on their characteristics. The prevalence of delirium in the overall community is about 1 to 2%, but increases with age, rising to 14% among individuals over 85 years old. Delirium occurs in 15 to 53% of older individuals post-operatively, and 70 to 80% of those in intensive care. Delirium occurs up to 60% of individuals in nursing homes and up to 83% of all individuals in their end-of-life stages. Development and course of delirium. According to the DSM-5, majority of individuals with delirium have a full recovery with or without treatment, and early recognition and intervention usually will shorten the duration of it, but if left untreated, delirium can progress to stupor, coma, seizures, or even death. Mortality among hospitalized individuals with delirium is very high, and as many as 40% of individuals with delirium will die within a year of diagnosis. That's in hospitalized individuals. So looking at risk and prognostic factors, environmental, delirium may be increased in the context of functional impairment and mobility, history of falls, low levels of activity, and use of drugs and medications with psychoactive properties. Genetic and physiological. Both major and mild neurocognitive disorders can increase the risk for delirium and complicate the course of it. Again, older individuals are especially susceptible to delirium compared to young adults. Functional consequences and differential diagnosis. So, delirium is associated with increased functional decline and risk of institutional placement. Hospitalized individuals 65 years or older with delirium have 3 times the risk of nursing home placement. Looking at differential diagnosis, the most common issue is evaluating the symptoms of delirium and dementia. The clinician really has to determine whether the individual has delirium or a delirium superimposed on a pre-existing neurocognitive disorder like Alzheimer's and so on. Also, hallucinations and delusions that resemble delirium must be distinguished from psychotic, bipolar, and depressive disorders with psychotic features. So you have to be really careful when diagnosing. Other specified delirium and unspecified delirium. These are 2 separate categories at the end of the delirium section in the DSM-5. The DSM-5 states that the category of other specified delirium applies to presentations in which symptoms characteristic of delirium that caused clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria of delirium. So this is what they call the attenuated delirium syndrome. And then lastly, unspecified delirium. This comes in cases where it's a weird setting, like an emergency room setting. The clinician will choose not to specify the reason that the criteria is not meant for delirium, and includes presentations for which there is insignificant information to make a more specific diagnosis. So yes, like quick emergency room settings. That concludes my portion of the presentation on delirium. Thank you.